When a patient comes to you with signs and symptoms that is pertaining to DVT or PE, it is at that time we have to look out what are the exact signs and symptoms that we have discussed here. Patient can have a tachycardia, syncope. Patient can be hemodynamically unstable. There can be RV strength pattern in the ECG. Patient can have tachypnea, dyspnea. If you do a AVG, you will find there is hypocapnia, alkalosis. And patient can present with hemoptysis, signs and symptoms of DVT, swelling of left, pain and tenderness, right? So then you go to the history of the patient and find out what are the predisposing factor that is present in that patient. What are the predisposing factor? Anything that disrupts the work stride that we have discussed, right? Now we have a patient which is called suspected PE. So suspected PE is equal to signs and symptoms plus predisposing factors, right? So then whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, it is at that time you go ahead and do an transthoracic echocardiography. And what are the findings we have discussed? You can have a RV dilatation, RV to LV 1:1, septal flattening, TAPSE, which is a marker of systolic RV function, maybe less than 15 millimeter, and you can see a streak of thrombus going from right atrium to right ventricle, right? If these findings are present, that means it is suggestive of PE. So you go ahead and treat the patient for PE. However, if the patient is hemodynamically stable and there is signs and symptoms of DVT in that patient from history, you go ahead and do a compression ultrasound. 4-point method, 2 inguinal, 2 popliteal. And if you see a filling defect, that is diagnostic of DVT, and you immediately treat the patient for PE. However, if there is no history suggestive of DVT and compression ultrasonography is negative, patient is hemodynamically stable, then you put those patients in a filter method, 2-step filter method. What are the 2 steps? We have clinical predictive value and prediction criteria. Using either of them, you have to divide your patient into low risk or high risk. Those patients who are in low or intermediate risk, they will go ahead and do a D-dimer test. If the D-dimer test is positive, they will be done a CTPA. If the CTPA is positive, you will have to treat for PE. However, because D-dimer is a very highly negative predictive value, if it is negative, it virtually rules out PE. However, those patients who have a high risk, they can go ahead and directly do a CTPA. If it is negative, it rules out PE. If it is positive, you have to treat for PE. There are certain patients in which you cannot do a CTPA. Young patient, pregnant, contractile general failure. In those situations, you have to do a VQ scan. If the VQ scan is positive, you have to treat for PE. If it is negative, it rules out PE. All those patients who has been diagnosed positive for PE, one more thing you have to do. You have to risk assess the patient and prognosticate. Severity assessment you have to do. And for that, we use 4 methods or 4 criteria. 1, clinical criteria. 2, comorbidities. You can add these 2 things, what we call as the simplified PESI criteria. Then you have to assess the RV function using imaging and biomarkers. Patient, those who are high risk, they are the hemodynamically unstable patient. They are the patient who are going to die in the hospital. Then there are intermediate high groups, simplified PESI more than 1, and both imaging and biomarkers are positive. What are the low group, intermediate low group? Simplified PESI is more than 1 and either of them is positive. In the lowest risk group, simplified PESI may be 0 or 1, but the RV function, imaging and biomarker both are negative. So in this way, we approach the diagnosis of pulmonary embolism. Let us discuss the treatment of pulmonary embolism. For a fact, remember that pulmonary embolism is extension of a DVT. It is extension of a thrombus that is formed outside of the pulmonary system, right? So let us target how to get rid of this thrombus. The thrombus is generated by activation of a coagulation cascade, right? And then once the thrombus is formed, it has to be dissolved. Usually in a normal person, the thrombus is dissolved by using body's own fibrinolytic system. So when a patient presents to you with a hemodynamically stable state, it is at that time you can let the body's own fibrinolytic system to take over and dissolve the clot. There is no hurry. But whenever patient presents to you with a hemodynamically unstable condition, it is at that time you have to act immediately. You cannot let body's own fibrinolytic system to act, which is a time-consuming process. So you have to give clot busters. You have to give fibrinolytic agents, pharmacologic agents. Most commonly used are alteplase, which is a RTPA. The second method is to prevent the formation of thrombus or prevent the propagation or expansion of thrombus. That can be done by targeting the coagulation system. And the coagulation system can be targeted at various steps as described in this picture. Right? So when a patient presents to it with a hemodynamically stable condition, at that time you have to give anticoagulation. And whether you should give fibrinolytic agents or not depends upon the hemodynamics of the patient. If patient is stable, you can wait and let the body's own system take over the thrombus. If patient is unstable, you have to give alteplase or clot busters from outside to dissolve the thrombus. Now let us see how using this framework we can treat a patient of pulmonary embolism, right? After a patient has been diagnosed with pulmonary embolism, we have to classify the patient into different subcategories based upon few criteria. That is simplified PESI score and whether there is RV dysfunction in terms of imaging evidence and biomarkers present or not. The first group will be massive PE. The massive PE patient will have a sPESI of more than 1 and there will be RV dysfunction evidenced by imaging or biomarker both. But what separates this from other groups is presence of hypotension. So whenever there is hypotension, the patient goes to the ICU definitely and their treatment is thrombolysis. You have to thrombolyze the patient because patient is hemodynamically unstable. We cannot let patient's own body to take over, which is a time-consuming process. So we have to thrombolyze. How to thrombolyze this? You have to use alteplase 100 mg over 2 hours, giving first 15 to 20 mg as a bolus in the first 15 minutes. Now there are different strategies now coming up. We can give half dose also or small dose of alteplase also. But before giving alteplase, we have to check for contraindication to thrombolysis, right? Now, you can give anticoagulant to these patients, but this is not a treatment of these patients because patient hypotensive and anticoagulants do not dissolve the clot. They only stabilize or prevent further formation. But you can start it. We have two options. Either you can give unfractionated heparin or LMWH. Now the patient has been thrombolyzed. So when to restart heparin? If the patient is improving, then delay starting heparin because there will be high risk of developing ICH in this patient. So if patient is improving, you can delay the start of heparin. Plus, RTP or alteplase will produce a certain kind of coagulopathic state in the patient. Also, there will be hypofibrinogenemia, right? So delay. However, if patient not improving, start heparin without a bolus. And that too when FTT is less than 1.5 times to 2 times the normal. Thrombolysis is contraindicated or failed thrombolysis. We have two separate options. We can do surgical embolectomy or catheter directed thrombolysis. And both these conditions will be easy if patient was initially on UFH. Will be difficult if the patient is on LMWH because it has a long half-life. There will be high bleeding risk. Because short half-life, it can be stopped, reversed, down titrated, right, before doing an invasive procedure. The second will be submissive PE. These are the patients who has to be monitored in the ICU because they are at high risk of developing hemodynamic instability and transforming into a massive PE. By definition, they will have sPESI more than equal to 1, RV dysfunction as evidenced by RV imaging and biomarkers. But the thing that separates it is the absence of hypotension. But these patients can develop hypertension at any point of time. That's the reason why they have to be monitored in the ICU. Here, we use anticoagulant straight away because patient is hemodynamically stable. We do not use fibrinolysis agent. but we will use anticoagulants. LMWH is preferred than UFH. Why? So whatever you give, you have to bridge them to VKA, vitamin K antagonist. Those can be started on day 1 or 2. Patient is on ventilator, we can wait for some time, but usually it is started on day 1 or 2. You have to wait for INR for 2 to 3. Usually it takes around 4 to 5 days. After that, you can stop heparin and continue with the warfarin. Now there are different NOACs available in the market. We have two kinds. Beta 2 inhibitor, which is dabigatran, which is used with a bridge with the heparin for 5 to 10 days. The dose is 150 mg BD. It is contraindicated in renal dysfunction, and the reversal agent is idursulfimab. We have beta 10 inhibitor, that is apixaban or Eliquis. We have rivaroxaban or Xarelto. Both are given directly without any bridging, and both are relatively contraindicated in heparin dysfunction, and we have a reversal agent adexanet for apixaban and rivaroxaban. Now coming to symptomatic PE, these patients goes to ward because they have sPESI more than 1, but there is no evidence of RV dysfunction. And then you have a subcategory called asymptomatic PE, means these patients are accidentally diagnosed PE. They are being investigated for something else. Accidentally found they have a PE. So they will also be started on heparin and to warfarin bridge or NOACs. But these are the patients that can be discharged home the second day, provided they have easy access to hospital, they have caretaker at their home, right? So this is how we treat a patient of pulmonary embolism. Thank you very much.